Oh, that wasn't just... Okay. Now for stage 3.
The following is a Cable 14 special presentation.
Hello, everyone. Thank you for coming this evening. My name is Paul Burton. I'm the editor-in-chief at the Hamilton Spectator. Like many organizations and businesses in Hamilton, the Spectator has much in common with the Community Foundation. Both of us, after all, are interested in the prosperity, health, and safety of the community. And in fact, though some of you might not recognize it and others might not disagree, that is in fact what we do every day in every story in the paper and at thespec.com. We are comfortable with that mission and we try our best, and we very much appreciate the efforts that all the other organizations in this city do as well. And none so much as the Community Foundation and the work they do through vital signs, which help us all understand where we are and how much more work we have to do. So I am pleased to be here on behalf of the Spectator to welcome you all, and thank you for coming tonight. And with that, I'll throw it to Terry Cook.
Well, welcome. Thank you, Paul. It's always good to follow my friend to the microphone. We sport the same basic white on black kind of Roy Orbison look, very handsome haircut, and a deep commitment to Hamilton. I always like to start by acknowledging that the Spec is a daily newspaper that we should be both very mindful of and appreciative for. In a time in which journalism, daily journalism and daily newspapers are struggling and suffering and attempting to reinvent themselves and frankly have diminishing capacity to cover stuff that matters, they continue to hit way above their weight. And specifically the work on Code Red that really has shaped the conversation around poverty in Hamilton and its effects on health and educational outcomes in particular. That's game-changing stuff. It's won the appropriate national awards, and that's not something that adds to the bottom line of the Spectator, but it's very much a part of the shared values that we and they partner on events like tonight. So thank you, Paul. Thanks to Steve Buse for the great coverage on vital signs this year and the piece that was in the Hamilton Spectator today. We're here tonight to talk about addictions and mental health and the latest release of the Community Foundation. It's an opportunity for us to talk to a community, to engage in both some expert commentary on trends that are affecting this community, challenges that we are attempting together to overcome, and its way in which to stimulate conversation and, we hope, action. We have an outstanding panel tonight, but I need to start with a couple of preliminary items, and the first would be to acknowledge that tonight's event is being supported by the Carolyn Milne Fund at the Hamilton Community Foundation, a fund that was set up to honor the leadership that Carolyn provided to the Community Foundation. She was my predecessor, served in the CEO's role for 13 years, and continues to be a very vigorous presence and leader in our community, and that fund is supporting events like this, and particularly it's supporting what we're doing here tonight. I want to thank the advisory committee that helped us to vet and to disseminate the information that you read in the Spectator and that you can see online, and in particular recognize the leadership of Dr. Leela Ryan, who has chaired that committee now for us for a number of years and who has a long tenure of service both broadly in healthcare in Hamilton, but specifically in leadership at the Community Foundation. I want to acknowledge the public health team who are our partners in this work. Dr. Elizabeth Richardson is going to be part of the panel here tonight, but her team were absolutely instrumental not only in the work that we do on a day-to-day basis together around mental health and addictions, but specifically in helping to populate the data that you're reading in this report. My final thank you is to our team at the Community Foundation, and I would specifically, I'd be remiss if I didn't acknowledge Grace Diffie and Michael Parente, who led the effort, to Chris Farias from Rebel Unicorn, who did the creative on it, and to all of the other constituent parts of our team who are here supporting the event tonight and who continue to make me proud and each and every day to be able to do this important work. So with that, let's get to the subject matter at hand. I would tell you that the good folks at Cable 14 are televising tonight. They're going to be showing this on multiple occasions over the next month, so if you're not inclined to approach the microphone or be profiled, you'll just be forewarned that this thing's being televised, and please govern yourself accordingly. We're going to do a couple of things tonight. First of all, I'm going to ask Jeff Wingard, who was really the project manager and the steward on this project, to come up and do a Reader's Digest condensed presentation of the findings in this Code Red report. We're then going to invite our expert panel up. I will ask them a few softball questions, let them open the dialogue and talk about the work that each of them and the perspective they bring to the important conversation that we're having. And then, as always, we will open it up to the audience. My only request of you is that if you're comfortable with it, identify yourself. If you happen to be with an organization, tell us who you are, and then try and get to a question that's relatively succinct, and respect the fact that we'll try to get through as many questions as we can. I think that we've got Tracy Varco and Shyla with roving microphones, so just put your hand up, and we're in Hamilton, so elbow your way to the microphone, and don't be bashful. We don't stand for shrinking violets in this town. So with that, let me introduce Jeff Wingard. This is Jeff's bio. Jeff brings over 20 years of experience in local poverty reduction, affordable housing, and social policy analysis, and consults on quality of life projects for many local organizations. Those projects include co-directing McMaster's Office of Community Engagement, City Lab, a partnership between McMaster, Mohawk Redeemer, and the City of Hamilton, and serving now as the project director for Hamilton's development of an Ontario Health Team submission, very current, and I'm sure that we'll be talking about that tonight. On a personal front, here's what he says. Jeff lives with his family in Dundas, and on Monday nights he likes to outscore, out-rebound, and generally outplay Terry Cook on an elementary school-sized basketball court. I hope that the professional part of the bio was more accurate than the personal part. All I can say is that Jeff was born and raised in Indiana, and from the land of Hoosiers and Bobby Knight, it's an abomination what he does on the basketball court. But he's a good friend, a dedicated researcher, and I'm honored to ask him to open the program here tonight. Jeff Wingard.
Thanks, Terry. Always a pleasure getting introduced by Mr. Terry Cook. Never know quite how that's going to go. Have to take it out on next Monday night. I'm here to talk to you a little bit about the most recent trends in mental health and addictions that we were able to put together for you. Just a little bit of background on vital signs for those who aren't aware. This is a report that is produced across the country in cities across the country with community foundations to really give a snapshot of trends that are important to community life. We emphasize research that you can read. We like to keep it at a high level to look at trends and comparisons between different communities and the provincial averages. And really we intend this to provide some insight, awareness, and a starting point for discussion. So my job tonight is to kind of run through some of the trends that you have in the 4-page handout. I'm going to talk a little bit about themes that cross those. I'm not going to go through line by line. And then we're going to hear what some of the experts have to say about these trends. Just a quick review of the advisory committee that we asked to help decide which trends we include, how we understand and interpret those trends, and then how we present the data in a way that is manageable and meaningful. This is a really fun group to work with, actually. They're all data gurus in their own right. and you put all of us in one room, and it gets a little bit silly how excited we get about numbers and trends, and we start shouting and yelling, but at the end we have a really great product, so it's a privilege to work with those folks. When we do the full vital signs, we do this every 3 or 4 years, we look at a number of different issue areas. So you'll see all the way from arts and culture to safety to environment to housing. And it's a really interesting report to do from a research point of view, because you get to kind of dabble in lots of different areas. One of the things that we heard from folks is that they wanted us to do a bit of a deeper dive into certain areas that were more pressing or more of interest to current issues. So in the spring, many of you will remember that we released a seniors update that had a lot of information about some of the challenges facing older adults and some of the remarkable things that were happening with that group. And then the next, this iteration, we wanted to focus in on mental health and addiction. As Terry mentioned, this really builds on a partnership with the city's public health department. Some of the research that you're going to see was presented to the Board of Health or City Council in February of this year. And it integrates an analysis by the Spectator, as Terry mentioned again. Some of the neighborhood kind of comparisons that we were able to do really relies on the work of Steve Bust and team to understand what's happening at smaller than the municipal level. We're going to talk a little bit about indicators at the acute care level, so that's really hospitalizations and then risk factors. The hospitalizations and acute care are really the tip of the iceberg of what's happening, and they really are indicators that we need to keep track of. We know that they are indicators of the iceberg getting bigger or smaller over time, and so that's what we look at. We also, again, will then try and focus in on some of the risk factors. So now into the data, we're going to talk across 3 or 4 different themes. When we looked at this data, we were quite perplexed, I have to be honest. This is one of the first times that as a vital signs researcher, we looked at this data and said, wow, this is, we're really finding some really concerning trends. I'm going to hit on a couple of them here. 3-fold rise in both opioid overdoses and deaths, and we're 60% higher than the provincial average. In numbers, this is 37 deaths in 2012 to 122 deaths in 2018, and that trend has continued to rise. There's been no shortage of coverage of this issue, but it certainly is worthy of our attention urgently. We also saw some double the number of emergency room visits for other substance uses, so things like marijuana, alcohol, not quite alcohol, sorry, cocaine and crystal meth, methamphetamine, had all doubled over the past 5 years. Those, just to give you a sense, those went from about 35 visits a year to 75 a year, so they were still relatively small numbers. Opioids were at about 470. So there was a huge jump between what's happening in the opioid addiction world. We also saw a rise in hospitalizations for mood disorders, so that's depression, bipolar, and kind of low-level depression, dysthymia, and self-harm. So we saw, and that was across all ages. We're going to talk a little bit about what's happening in youth and some gender comparisons in a minute. But even when you look across the board, we saw this going up. We did find some signs of progress. Daily smoking rates. So smoking is one of the leading causes of long-term health problems. And we are decreasing continuously, which is good news. If you look at the second bullet, smoking abstinence rates, that means the number of youth who don't start smoking at all has gone from 3/4 in 2003 to almost 9 in 10 a few years ago, and that's continued to grow. So this is great news in terms of long-term health problems for folks in our community. The percentage of heavy drinkers and the number of drinkers that are exceeding the low-risk guidelines is staying steady. We're a little bit below the provincial average in that case. and the number of hospitalizations for alcohol toxicity is edging down a bit. So these were encouraging signs in the midst of a pretty challenging report. We did want to spend a little bit of time talking about trends among children and youth. This community, along with other communities in Ontario, does a survey of all senior kindergarten students, and teachers evaluate them across 5 domains. It's called the Early Development Instrument, and we're able to look at different neighborhoods and across the community. One of those domains is socio-emotional health, and we've seen that is a relatively large jump between 2012 to 2018. It's stayed steady for the last few years, but again, we're watching this trend very carefully. We've seen a huge jump in child and youth hospitalizations for anxiety, 8-fold. In the rate for that has gone from, so when we talk about rates, we do it in per 100,000 population so that we can compare small towns and big towns. The rate jumped from 20 per 100,000 to 187 per 100,000 in the last 5 years. We also saw that in terms of self-harm, females under 20 have the highest rates. It's 3 times the rate of the general population, and it has risen. It has risen by about a quarter in the past 3 or 4 years. And to give you a sense, per 100,000, the general population I think is about 120, and females under 20 are 410 per 100,000. So this is a really, again, disturbing trend that we need to keep our eye on, and I'm sure the panel will talk a little bit about that. We don't have as much data about children and youth as we would like. It is coming. The city is developing it's called the Middle Development Instrument. It's like the Early Development Instrument, and we will start to have data in a couple of years on that. In the meantime, this is regional data from the Center for Addiction and Mental Health in Toronto. So they did some regional studies. So this loops us in with Niagara, Brantford, and Waterloo-Wellington, but you will see some trends that I think do require some mulling over. So double the number of high school students report mental health over the last decade, and we're seeing increases in the number of hours daily on electronic devices. If you're a parent with a teenager, I'm sure you won't disagree with that one. So this is wrapping up now, but one of the things, again, just a shout out to the research that the spec has done with Code Red and some of the prior work that we've done, which really raises some cautions about thinking that our citywide averages are telling the whole story. So when you look at self-reported mental health, we look about the same as the province of Ontario. About 2/3 of folks are saying that I have good or excellent mental health. But when you break that down, for this particular example, we're going to break it down by age. So you'll see that in terms of self-reported mental health, the 35 to 49 or the 18 to 34 are the highest, most likely to report good or excellent mental health. 50 to 64, I don't know if there's anybody in this room that's 50 to 64 years old. I won't ask you to raise your hands. But the 50 to 64-year-olds are also the most likely to report quite a lot of life stress, nearly 3 times the amount of teens. And I don't know if this is a total indicator that there's hope at the end of at retirement age, but it might be. But you will notice the real variation between these groups. So there's a couple of other examples that we wanted to pull out for you. When we looked at, there's an excellent report by Jeff Martin in partnership with Wayne Luchuk at McMaster that goes really in depth on trends among millennials. And one of the things they looked at was their precarity of work and how that affected their mental health. So when you looked at millennials who had precarious work, they were 3 times more likely to report fair or poor mental health. When we look even at a population of Two-Spirit and LGBTIQ plus population, even within that group, there are huge variations between over 50% and 25% when you look at subgroups of that population. Alcohol use, 60% of young adults are exceeding the low-risk guidelines compared to 43% of Hamiltonians. When you look at smoking rates, there's some recent research by the Indigenous community showed that over 2/3 of Indigenous folks in Hamilton are daily smokers. And I think the other thing to remember is that, and then when you look at gender, the gender picture for both mental health and addictions looks very different depending on women or men. Women have a very different trajectory with both addictions and mental health. So this is just another reminder to dig deep in the statistics that you see, and to keep in mind that one line is not going to tell the whole story, and there is a lot of variation between groups. So we did find a fair bit of material to be concerned about. We did find some hopeful signs in terms of some of the topics that we looked at, but then we really wanted to spend some time talking about some of the troubling trends that we're seeing here in this vital signs. So, thank you. Terry?
Thank you, Jeff. Can I ask our 4 panelists now to join us on stage? And what I'm going to do is introduce them sequentially, ask a question of each of them, and then we'll go down the line as we introduce the balance of the panel. And I will start with
We're not sitting in the order.
Tim O'Shea. You're in the wrong order. You're messing me up.
All right. Did we screw that up? I'm sorry.
That's okay. That's right. I'm a liberal arts guy. I can deal with this. It's not a problem. Dr. Tim O'Shea is an associate professor in the Department of Medicine at McMaster University and practices as a general internal medicine and infectious diseases specialist. He's a member of the Hamilton Shelter Health Network, the Hamilton Social Medicine Response Team, and the Inpatient Addiction Medicine Service at the Hamilton General Hospital and St. Joe's. Tim, starting with you. As we have seen, not all drug overdoses situations end up in the emergency room, but it is what we can count. There's certainly more. And what I'd like to ask you to do to set the table for us is paint the picture of what you're seeing out on the streets now, because you are working at a very granular level with addictions and mental health in this community.
Sure. Thank you. And thanks for inviting me and letting me be here today. So as Terry mentioned, I work with an organization called the Hamilton Social Medicine Response Team. That's where I spend most of my time. And with that organization, our work is primarily with patients who aren't being seen in the traditional medical system. So they're not being captured a lot of times by these statistics. They're folks that aren't comfortable seeking care in the emergency room or in traditional settings with doctors and nurses and other healthcare professionals. And so you're right, the statistics that we see in terms of overdose and visits to the emergency room really are the tip of the iceberg. For my patients that we're dealing with on a day-to-day basis, these folks often do have overdoses that are dealt with in their community by their friends, by their family, aren't seeking care in the emergency room for each of their overdoses. As well, my patients oftentimes have very, again, unmet medical needs. We've lost a number of patients in the last year due to serious bacterial infections that have come as a consequence of injecting. We've had patients that have had serious trauma, broken bones, other MSK complaints and things of that nature as a result of engaging in dangerous activities that they need to engage in to access an unsafe drug supply. And as Sue will talk about, I think as well, my patients oftentimes have very unmet mental health needs that aren't being captured again by these stats here.
Thank you. An issue that is current and topical that affects many of the people that you deal with is one that the city and the Shelter Health Network have been both struggling with and advocating for, and that is the future of the Wesley Center and the need for a permanent safe injection site. Can I just put you on the spot and ask you about the importance of that work and where we hope to land?
Yeah, I mean, I can start with the Wesley. Again, I'm a big fan of the Wesley Day Center. I think it's a very important service in our community. Again, for the patients that we see with HamSmart in particular, the one thing that we hear over and over again from our patients is that they don't really have a lot of places where they can just be and be comfortable and not be moved along and not be told, you can't be here, go somewhere else. You can't be here, you can go somewhere else. And for a lot of the patients that we deal with, the Wesley Day Center was a place where is a place where they do feel comfortable. And the benefit for me of that organization and having a place where my patients feel comfortable is it helps me be able to find them and to know where they are. And so oftentimes, again, we'll lose touch with people because of whatever life circumstances come up, and then we'll get a call from one of the public health nurses at the Wesley or one of the shelter health doctors at the Wesley and say, okay, so-and-so is here, can you come down and see them? And that gives us a chance to re-engage. So I think having that service where people do feel comfortable, where they can access a number of different services is extremely important. And then I think the question around the permanent overdose prevention site, or CTS, or however it's phrased now, can't be understated. I think it's extremely, extremely important for Hamilton. I think we're underserved already in that respect. I don't think that we have enough of that service already in our community. And so I know, again, public health is working on securing that, and I think it's, I don't think it can happen soon enough. It should have happened probably yesterday.
Thank you. I'm now going to turn to this end of the panel, another guy with an outstanding haircut. There was a bias when we selected the panel. David Hoy is the manager of social work services and mental health at the Hamilton District School Board, Hamilton-Wentworth District School Board. He leads the board mental health leadership team, which is responsible for the development and implementation of the mental health strategy. Before coming to HWDSB, David worked in child welfare, children's mental health, and youth justice. We would be remiss if we didn't acknowledge the tragic murder that happened in one of our local high schools this week at Churchill High School, and extend our condolences to the family, to that school community, and to your board. And maybe that's a place to start. Obviously, your department have been providing essential services and support to that school community. How are they doing? And let's talk about the broader ramifications of what's going on with mental health and addictions in the school community.
So thank you, Terry. I want to express my condolences to the families and friends that have been impacted by Devin's death. I think, needless to say, it's really shaken the Churchill community, the surrounding feeder schools, other community members, but I think in fairness, it's really shaken Hamilton. It's a really different thing for Hamilton, and I think it's definitely impacted all of our schools. I would assume the schools and the other boards as well are feeling the reverberations of this. I think support extends beyond just mental health support. It's rallying a community. We need more than that. It impacts on so many different levels. Takes some of the basic, simple little things. Threatens your safety, your security. It takes away some of the sort of pillars of our community, which is your community school, where you should be able to go and feel safe and experience lots of fantastic opportunities and experiences and relationships. So I think there's some real core pieces that get shaken when things like this happen, and it's not sort of just a return to normal. There's a new normal, maybe, hopefully. I think initially, shock, we need to deal with that. We need to make sure there's lots of different supports. It impacts on the young people, obviously. It impacts on them at different. Some were very close friends of the young people involved. Some didn't even know them, but it happened in their community, so it still scares them. Some have previous trauma histories. It can trigger those events. Some have other pre-existing or underlying issues. If you're a highly anxious student who feels unsafe going to school, how does something like this trigger already challenged thinking patterns? We also have staff in the building. We ask them to be caring adults. We have staff in the building who are first responders. This isn't what they expected to be doing. So how do they recover from that? And are still available to support the young people and the different signs of grief, sadness, anger, frustration, fear. So I think you see it all. Then the community members, we want our parents and our caregivers to feel safe when their kids come to our schools. If they don't, how does that impact on the young person's ability to come to school and feel like it's where they're supposed to be? And there's a sense of trust for caregivers because you don't get to see your kids as they walk out your door. You don't get to see them till they come home, so you want them to be safe. And you don't get to see the stuff that's happening. So I think that's really, really frightening. Initially, I think we have to meet young people where they're at. We don't want to impose our thoughts on what grief should look like, on what help should look like. We have to accept that they'll have their own ideas and their own ways of managing, and try and shape and guide those to the best of our ability, but give them an opportunity to experience some of the tragedies. We don't want to pathologize real emotions, fear, anger, frustration. Those are real emotions in a situation like this. We don't want to pathologize them by saying, talk to a social worker, they'll make this okay. It won't be okay. It's tragic. So I think it's finding that balance. The same with the staff. How do we talk to them? I must have heard that 50 times. I don't know what to say. Be a caring, empathetic, genuine person. Start with that. If we could all just start there as our baseline, I think we'd be in a better place.
Thank you. Without delving into the particulars of this situation, obviously bullying and the effect of corrosive social media is something that I see as a parent of 3 teenage kids, and most families are struggling with that. And I just wonder if you could share some perspectives on how that affects mental health, a sense of social isolation, a sense of belonging and inclusion in your schools, and what, if anything, can both parents and educators do to be helpful?
So maybe I can separate those
Yep.
two. They're different issues. They
Yep.
coexist, obviously. So bullying happens. It happens in schools. It happens in the communities. Adults bully. Kids bully. It's not a rite of passage. It's wrong. It's hurtful. It's insidious. I think sometimes people confuse bullying and conflict. Bullying and conflict are two different things, but people catch those. It's a fight and someone loses, so they're bullied. That's not necessarily true. Bullying is more insidious. Some people misrepresent bullies. I remember going to an in-service and they showed Nelson from The Simpsons as the big physical brute as the bully. A lot of times the bullies are kids with social capital. They're the good kids, the kids who do well. The kids, bullying is about isolation and power over. So if you have social power, you have an opportunity to exclude. So I think, so it's part of our culture, it's part of our communities, it's part of our way of managing. And it's really difficult to identify. If you have 5 popular kids who say they're not doing anything wrong and you have 1 kid who says they are, how do you tease out what's really happening? And how do you consequence? I hear all the time, take a zero standard approach and kick them out of school. 2 things I'd say is kids don't do better when they're out of school, and bullying doesn't stop because they can't come to school. Bullying doesn't happen in front of adults, typically. And especially as kids start to get older, they spend less time around adults, and social isolation is a big risk factor. Now with the advent of social media, it's a 24/7 hour environment. And people don't even have to be brave anymore to bully. You can do it anonymously through social media. I think it's, for all the wonderful things about social media, it's opened up some really dangerous doors for us. I would say bystanders, any evidence, do the research. If we can empower our young people to stand up with their peers and to encourage help seeking and to identify and come forward, there's a big difference between snitching or tattletaling than reaching out to help somebody. And I think the message we want to get across is helping somebody is a really positive attribute that we have to encourage more people to do. And standing up for your peers, even if you don't particularly like them or they're your friends, is a really strong attribute that we have to enhance and encourage people to do it. And one of the best ways to do that is to model that as adults. And I think as adults we can demonstrate to our young people that this is how we handle conflict, or this is how we support one another, and take a more caring approach as opposed to the shame and blame and isolate approach that we often default to.
Amen. Thank you. I'd like to introduce Sue Phipps, who's the Executive Director of the Canadian Mental Health Association Hamilton branch. She has extensive experience working as a registered nurse in mental health and addiction sector and other settings, including Hamilton's first overdose prevention site. Her career focus has been on equitable access to safe, effective, evidence-based quality care for people experiencing serious mental illness and problematic substance abuse. So, Sue, let me start by asking you about the supports that you offer in the community, where that fits with the broader cross-section of of health and social services that we're trying to integrate better in this community, and tell me what you're seeing on the front line.
Okay, thank you so much for having me here tonight. I'm humbled to be here, really. I've worked in the front lines for so many years, and particularly in the downtown urban core, and really do understand the experiences of poverty and what that looks like in terms of the impact on people's mental health. So at Canadian Mental Health Association, we have a number of different health and social services that we offer. We have programs, we have a partnership with the Shelter Health Network where we do have a primary health care clinic for individuals who are experiencing homelessness that don't have a family doctor and often have a co-occurring mental health and problematic substance use disorder. We also have intensive case management services for people who need sort of that higher intensity level of coordination of care and on a sort of a more long-term basis for individuals that are 16 years and older. We also have an evening social rec program, which is one of our quite unique evening programs that really speaks to being able to support individuals who have a disability and are experiencing social isolation, because we do know that that has a huge impact on people's health, both physically and mentally. So that is a very low barrier drop-in kind of a group where anybody with a disability can attend, and they don't have to have a formal diagnosis. We have also a court support program, which is one of our largest programs actually, where we provide court diversion for individuals who have a low risk offense and that we can show has been a result of a mental illness. So we divert them from the criminal justice system into the mental health system so that they can get the care that they need. And within that program, we also have diversion and a release from custody program where we try to link individuals who are in custody upon their release into the community, as well as a relationship with St. Joe's with the forensics outpatient clinic there, so that we have a transitional case manager that helps to bridge and reintegrate individuals who have been in the forensic system back into the community. So I'm sure I'm forgetting others, but we have lots to offer. Yeah.
So let me narrow the focus and ask you specifically to see, for you to speak to gaps that you see in the system. And could you also reflect upon, you mentioned homelessness and social isolation. Talk a little bit about the non-medical pieces like access to affordable and decent housing and where that fits in this equation. But start with gaps and touch on some of the other things if you would.
So thank you also for mentioning we do have housing support programs as well. So interestingly enough, when people are not able to find safe, affordable housing, of course it does very much affect their mental health. And what we do have is some funding for subsidy. Unfortunately, though, that subsidy, curiously, usually is attached to one individual. So that one individual has to be housed independently to be eligible for that subsidy. So therefore, they end up being quite socially isolated, living alone. And so, of course, we have, people that go in to help support them, but that isn't enough, and particularly after hours. So those individuals find themselves quite lonely in the evening and do seek support from the emergency department. So it has a huge impact on their ability to sort of reintegrate into the community. Yeah. And sorry, what was the other question again?
I think you've covered them both.
Oh,
so thank
okay.
you. But we're going to come back to you in the Q&A. Okay, our final panelist, Dr. Elizabeth Richardson, has been the city's medical officer of health since 1998. That was a very enlightened regional government back then that hired you, if you don't mind my saying.
A great regional
Inspired hire, I have to tell you. Elizabeth oversees the city's public health services goals to protect and promote our community's health through programs such as communicable disease control, supporting local families and their children's development, working with community partners to ensure the safety of our food, water, air, all along with improving equitable access to health and well-being. You have a much more distinguished bio beyond that, but I'm not going to read that because I want to put you on the spot. First of all, thank you to you and your team for being a part of really populating and supporting this important work and this conversation with the community. Your work touches almost all of the facets of what you've heard tonight. Reflect for us on what you've heard from the other panelists and what you've seen in the report in terms of the overarching challenges to our health and social service network and to the performance of the community's population health as it relates to addictions and mental health, because there's some troubling stuff here.
Absolutely. Well, thank you very much, Terry, for being here. It's been a privilege to be a part of this work. Our team that does this work, because as Jeff said earlier, a bunch of people love looking at data, but they like even more taking that data and looking at how people can understand it. So it's not just information, facts, and stats, but it's really, comes to light in terms of what it means for our community and what we can do about it. So, when we look at this data and put it all together, they've looked at things that make people ill, they've looked at things that cause people to die, they look at things that cut short lives early. And Jeff did a great job of highlighting some of the key things that we see there. And when we look at all of that, there's sort of two things that really come to light. And that is the unintentional poisonings that we see, and we see opioids and all the other substances that you mentioned, methamphetamines, cocaine, all of those things, cannabis as well, are really having a significant impact in our community. And the other is self-harm, particularly amongst young women. And so when we think about that here in our community, they really come from similar roots. They come from challenges that we're having as a society in terms of creating a place where kids can grow up to be healthy and strong, to be resilient, to cope well, where we have parents who have the time and have the understanding and skills to support them in that development, where they can develop healthy relationships, where we have environments that are safe and supportive. And so we look back at those roots and some of the things you've heard from Dave tonight about, the trauma that happens sometimes in childhood. And we talked about poverty. We've talked about the cycle of poverty and how poverty and mental health are really two things that go hand in hand. And so, when you're poor, you're more likely to experience those traumatic events, to experience things that then impact your mental health. And then if you have mental illness, mental health problems, you're more likely to be poor. And so there's a real chicken and egg scenario that goes on. But as well as we grow, there can be, other life events that come up, violence, all of those sorts of things that are traumatic and overwhelm our ability to cope and to develop those skills. And so we also see social isolation. We're talking more and more about that. We see that in people who are on the street. We see stigma. We see that as a significant issue and the kinds of things that go on with bullying and those sorts of things. And so really what we need to look at is how do we draw all that together to create those conditions where people can be as healthy as possible. And we're always in public health, we're always talking about that early intervention. How can we change things early on in that trajectory? How can we make sure that people have stable housing, that they have a stable income, that they are supported when they are struggling with issues? They've got the information that they need when they're looking at parenting issues and that sort of thing, and the supports that go on through their lives.
So you and I have spent a lot of time in a room over the last couple of years with hospital CEOs and city managers and primary caregivers talking about how we work better as a community. And you are now involved in what arguably will be the biggest transformation of local health and social service delivery certainly in the last 25 or 30 years. I know that the local health team has identified both complex needs of an aging population together with addictions and mental health as the three top priorities. Talk to us about how either optimistic or worried you are about how we come out the other end, because having lived through some restructurings, you and I, some of them end well and build momentum and get to a better place, and others don't. So without any partisanship, talk to us about that process.
Sure. So when we're talking about healthcare in Ontario, we know something's got to change. We know that, we've got to invest our resources differently. We need to do things differently. And we've been talking about that here in Hamilton for a number of years. We've been sitting around the table with leaders from each of the hospitals, from St. Joe's, from Hamilton Health Sciences, with our primary care leaders, our family physicians, from people in the community like Sue and people from all around the community agencies, and we all know we need to look at things and do things differently. So with this sort of history we've had here in Hamilton, we've got some pretty significant momentum behind us. And so the Hamilton Health Team initiative, that's part of the Ontario Health Teams, is an opportunity to do some things that are different. And I think it's really telling that whether it's at the Hamilton Health Team table with mental health and addictions in children and adults, or whether it's our work that we do with the school boards where mental health and addictions is a priority in terms of what we're doing there. For us in public health, it's mental health and addictions that we're doing there. This is an opportunity to get together, to look at how we're providing care, to make sure we're doing it in an integrated way, to make sure that it's coordinated, to make sure that people have the supports that they need, and that all of the providers within it are understanding what those are and how to work together. We hear, again and again from family doctors that it's complex, that it's difficult. They don't know where those resources are, where to go to. And so we all need to get together on that page. And I know Alex is in the back of the room there from Children's Mental Health, but really our Children's Mental Health, our early years groups have been on this journey for about 20 years. And they provide some really good leadership in where it can go when you do things well together.
Excellent. I was teasing Alex, by the way, that I don't miss seeing him every other Monday night, and we're happy at the Community Foundation to be financially supporting that project without necessarily having to sit through the very hard work that all of you are doing that really matters to the future of this community. This is the time in which we are going to open the conversation to the floor. We have at least 2 floor mics. I'm going to ask Jeff Winger to come on back up and take a seat with the panel. Again, Shyla has one microphone over here, and I think Tammy has one at the other side of the room. Who wants to go first? Please don't be bashful. Renee.
Great panel, everyone. Can you hear? Hello? Yes.
You're good.
Great. Great panel, and I really appreciate the depth.
Sorry, Renee, can I put you on the spot and just identify yourself and where you're from and fire away?
Okay, that might help. Hi, everyone. My name is Renee Wetzelar. I'm the Executive Director at St. Matthew's House. We're a not-for-profit multi-service agency on Barton Street between Victoria and Wentworth. And so at the heart of the Code Red neighborhoods is where we work and do a lot and see a lot of the things that you speak of. But one of the things that I'm struck by, and I think I need to bring this to the surface in this conversation, is the intersectionality that exists between race and also with the Indigenous population in this framework. I'd like to hear from your perspective about that. And also, my question might be as well, in terms of developing leadership within the community around that discussion, where are we at? I know that 5 years ago we had Curtis Bell in the McQueston neighborhood speaking with, a lot of the folks who are involved in a lot of these discussions. And there was a real big clanging bell that he was screaming about the fact that what we're also seeing is stuff that does involve those intersections and stuff that also involves gang-related violence. So can you tease some of that out for me, please, a little bit, if you wouldn't mind?
Who wants to go first? And we don't necessarily have to canvass the entire panel, but just I think I'm going to, actually, David, if you don't mind, I'll put you on the spot because I happen to know, because of the amount of work that we do together, that the work of folks like John Howard and the work on gang intervention is critically important in the community, and they've faced some very significant cutbacks in federal funding of late that has diminished their capacity in your schools. So do you want to try and touch on Renee's question and then more broadly about how we work together?
So I think the intersectionality amongst race, amongst our indigenous, I think if you look at any indicators about well-being, about academic achievement, you see certain groups, racialized youth do have poor outcomes, students identifying as LGBTQ, I2S plus have poor outcomes, indigenous youth have poor outcomes. When you look at metrics around mental health and well-being in the community, homelessness, addiction, certain groups, I don't know that you can separate mental health and equity. I think you have to sort of look at those through a lens that is inclusive. I think we have to look at the services that we offer and make sure they are truly inclusive, that they value different cultural expectations, belief structures, sense of self and identity, that the services are available by individuals who have lived experience and can share their experience with them. I don't think we do a particularly great job at that all the time. So I think that's a huge topic. I think we have a lot of work to do in that area around balancing the playing field. I think we have I think social justice is paramount to ensuring people have equal access to things that you need to be well. And I don't think we do that. And I think there's certain groups that are much further disadvantaged than others. And then when they experience more difficulty, we can sometimes label that as individuals. And I think, especially when you start looking at gang involvement, a lot of the research on gang involvement is around feelings of inclusivity, of being engaged. Sometimes there's a commerce piece to it. I think if we really want to address gangs, we need to address the underlying reasons that young people can find their support structure in that vehicle.
Anybody else have a question?
So just wanted to speak a little bit to the trauma piece around the Indigenous peoples that are in Hamilton, and just the fact that this intergenerational trauma, we really need to understand the impact of that in terms of their ability to access and trust the system, and to really be culturally sensitive in what we have to offer. And we do have the Hamilton Indian Regional Center on the mountain, and we have the Aboriginal Health Center as well that has a lot of support and services available. They do great work, and sometimes that isn't where Indigenous individuals want to access service, and certainly I've provided quite, service to individuals over the years who have chosen to seek services in different locations because of family connection or whatnot and wanting some anonymity. So I think we just need to be aware that we have to offer many choices to individuals, and that the distrust of the system is real and fair, and we need to have low barrier access for individuals.
Yeah, I think I'd just echo what Sue was saying. I think again, the groups that I work are primarily people that are uncomfortable being in traditional medical settings, and a lot of the work that we do is with folks who don't feel comfortable because of stigma related to drug use in particular, and there's still a lot of stigma in the healthcare system around drug use, but that's compounded, and certainly racism exists within the healthcare system, and it's something that I don't think we do talk about a lot, at least within the circles that I travel with in the hospitals, and so I do think it's something that we do need to pay a lot more attention to.
Yeah, and I will echo my long-held concern and challenge that when we think about housing policy in particular, and we look at the increasing segregation by race and income of our neighborhoods, that very much is a canary in the mine shaft. And the notion that politically there are certain people that simply by virtue of the way in which we design and exclude. 50 years ago we did it explicitly. Now we're doing it in a more nuanced way, but the outcome is still the same. Almost all of our residential care facilities, I know Steve Bust is working on some focus around where do we locate critical services and subsidized housing units almost exclusively in the same neighborhoods that already have the lowest incomes and the greatest challenges. Whereas we know that better outcomes happen when schools have mixed incomes and neighborhood provide housing opportunities for a range of different income mixes so that our populations truly are integrated. And we're not doing that. We haven't done it for a very long time, and we're paying a price. I'm going to go back over here.
Thanks. Hi, Medora Upel from YWCA Hamilton. I'm the Director of Operations there. So I just want to pick up on a point that Jeff made earlier that at the beginning, saying we need to dig deeper, and particularly when it comes to women. I think that we failed to dig deep enough when we're talking about mental health and addictions. That the issues that women face are particularly complex and unique and distinct from those that men face in our community and have to be addressed in a different way. And just also to add and pick up on what David said about pathologizing some of behaviors. For women and for girls, often they're responding to experiences of violence and trauma that result in becomes pathologized and becomes mental health and addictions behaviors that get treated through a illness lens rather than seeing it through a survival and a resilience lens. And I think that becomes problematic in the way that we judge and we approach women and girls in our community. And the fact that we just do not talk about violence and trauma and the how disproportionately women, and particularly women of some communities, face compared to other women. And we need to do a better job of exploring that and talking about that in our reports, on our panels. Not a criticism of this panel. I have much respect for many people on the panel, or everyone on the panel, I should say, not to single anyone out. But I think we need to just do a better job as a community. And you spoke about the Wesley Day Center, and I just want to pick up on a piece that we have up to 200 women without any place to stay. We know that in our community. They don't have access to shelters. They can't access transitional housing or affordable housing or anything else. They're dealing with complex mental health and addictions issues. And this winter, there's just no money available to provide any support to them. Even though we've been doing it for the last 3 years, scraping together and figuring out how to do this, come December, we're not going to have options. And we have at least 200. We know there's probably more out there who will have nowhere to go and no options. And that's, I think, a failure to talk about this issue from a gender lens.
You're so right. Great point. And who wants to take a run at it? Tim?
Yeah, I mean, we've been, with our organization, we've been really, really struggling with this issue in particular in the last probably couple of months in particular. I don't know if it's become more acute in the community or if it's just become more apparent to us. Lisa Nussey's here in the crowd. She's a coordinator on our team, and we were reflecting on the way over where she said, you know, we've had a couple of people where we had to sit in front of them, really, really sick, people with very serious physical and mental health needs, homeless, living on the streets, who have reached out to us and asked for help. And again, we can provide the medical care, but we can't provide housing. We don't have housing, and like you said, there's just oftentimes nowhere for people to go. And so we have had those conversations where we've had to say, I'm sorry, there's nothing that we can do for you, and it's heartbreaking, obviously, and I think it is for us right now, it's the biggest issue for sure. Lack of access, particularly to housing for places for women to be in Hamilton, I think is the thing that we've run up against over and over again, and we don't know what to do about it. I don't know if anybody else does. If they want to talk to us afterwards, that would be very helpful.
Anybody else on the housing question?
Not per se the housing, but just in terms of women feeling comfortable accessing services in general, I think that has come up as an issue, and particularly, interestingly, around overdose prevention sites. You know, they also need to be able to access safe places to inject, and often don't feel comfortable in a more male-dominated situation where they're injecting side by side with, you know, males. And so this is I was involved in a research study actually through Toronto, through CMHA Ontario, where they're really looking at gender at overdose prevention sites. So it'll be interesting to see what they come up with in terms of a need. Some sites are doing, you know, one night that's available only for women, but it's not enough, you know. So it's a very important issue. Thank you, Medora.
And again, on the housing front, for quite a period of time, we've been talking to folks both at the city and the planning department, Paul Johnson and Jason Thorne, about the need for a comprehensive affordable housing plan, which we think is critical for the community. When you look at the pivot we're about to make with LRT, there have been an extraordinary number of properties that have been acquired by the province and that will be put back into the private market, and we need to make sure that in doing that there is not a significant displacement, and also that we find ways, as we've done, because we're a significant investor in affordable housing projects with Indwell and Sacagawea and others in this community, to make sure that in each of those communities as change happens, that we protect space for people both who just have needs because of their income levels, but also where they have complex health and social needs as well. We need to find a way to get that work done so that all of us working together can figure out how much of that is government money, private development responsibility, philanthropic capital, whatever we need to do to figure out a way to bring at scale much more affordable housing into the marketplace. Failing that, we are facing an emerging crisis. And you just need to look to Vancouver and some other superheated markets to recognize that the price that is paid to the greatest extent is by the most vulnerable, marginalized, low-income populations. And prosperity is a good thing. I'm an LRT supporter, but we need to understand that as change happens, it is going to affect communities, and we need to figure out a way to get there. Steve Bust has a question. He's always understated and self-effacing.
Steve Bust, Hamilton Spectator. But I'm Steve Bust, private citizen tonight. So I'm not sure if this is a question for which of the panelists. Feel free to weigh in. So the numbers that I see and work with suggest that there's a mental health, I'm not sure if crisis is the right word, but I'm going to use the word crisis in Hamilton. Certainly the numbers are escalating rapidly. So the pendulum at one time was to institutionalize people with mental health issues. We would just put them away in a facility. And then the pendulum swung towards deinstitutionalizing people from facilities and put them into the community. And that doesn't seem to be working right now. And so my question is, why isn't it working? And what would work? And what has to happen?
And Steve, do you want to direct the question? Or
no, anyone but Terry.
My buddy. Elizabeth Richardson, I'm going to put you on the spot to start.
So I'll start it off because I think it is a really interesting question about institutionalization that we had previously, and then you swing to this deinstitutionalization. And one of the big faults with that swing was the supports didn't swing with it. And so we had these institutions where you had care, may not have been the best, may not have been a great environment, but at least it was there. And then as things moved out, that all those resources kind of went away to other things. And so we ended up with the population now in the community without the kinds of supports that they needed to have there. So when we talk about housing with supports, that's an absolutely critical part of what's missing. And we don't have enough of housing with supports. And what do those supports mean? And how much of it do we need? And, you know, Paul, who you talked about earlier, that's one of his big questions that he's looking at right now. We didn't have all the services follow those things. We don't have them organized. Like the work that Tim is doing out on the streets looking after people, that the Shelter Health Network is doing, is trying to cobble those supports back together for people where they are. So we have them there in patchwork right now, but we don't have them systemically. And so I'll turn it over to, I know these two will have a lot to say about those things.
Sue, go ahead.
So, of course, I have worked both in acute psychiatry in a hospital on the unit and sort of watched that revolving door of people coming in very acutely unwell and, you know, we providing medications, turn things around, they're back out, but they're dealing with the same level of poverty and social determinants of health that turn their health back around into a crisis again, and they end up back in hospital. And it is true that community mental health services have been chronically underfunded. I would agree with that, of course. I'm going to be a bit biased, but I will try not to be. In my role within the community, of course, the services that we offer, really the intent is to help people to stay in community and not to be in hospital, because we recognize that hospitalization is actually an interruption in their recovery. Sometimes, of course, it's very necessary when you're acutely ill and you do need to have that level of support and intensity. But ideally, if you can be supported in your home, in the place where you live, in your community, with your family around you, supporting you, you're going to have better outcomes. So that is what we want, ideally, and I think that the intention was excellent. You know, with the new medications that came out at that time, I remember because I was a nursing student, and there were some miracle drugs out there that were turning catatonic, you know, psychosis into functioning humans again, right? So this is amazing, right? But again, you know, the supports were not there, enough of the supports to help to keep people well in the community. So we still do need to do that.
Tim?
Yeah, I mean, I'm not a mental health expert. I'm an internal medicine and infectious disease specialist, so my knowledge around this issue is maybe a little bit more limited. But what I would say is that even though I am an internal medicine specialist, probably about half of the referrals that I get have some mental health piece to them, and I think that what's being said is correct, and I think it reflects that maybe the patients were decentralized, but the services weren't decentralized. And so oftentimes I'll get referrals for patients who have serious mental health issues, who are stuck in their homes or find it very hard to get out of their homes. And so they can't access the services where they are, and it's hard to find services to come to them. And then I think the other piece is there still is a lot of rules in healthcare that just don't make sense a lot of the times, and it's really hard to change those rules. So oftentimes community providers will ask me to go and see somebody at their home because in order to access the mental health care, they need a doctor's referral. And so if they don't have a doctor's referral, the mental health service can't see them, or West Fifth won't see them, or whoever it is won't see them. And so then I'm just going to their house basically just to say hello and to meet them and get a bit of a history and fill out a form so that they can access those services. When it would be much more efficient if the people that are in the community already could just refer them up to the appropriate services.
Going to go back, Tammy. Yep.
Hi, I'm Mary Jackson with the Healing Oasis program, and I just wanted to comment on the housing situation. Hamilton is one of 5 cities in Ontario that has second-level lodging homes. Now, 2 of them needed to be closed down recently. And I work closely with the Indwell people who are trying very hard to provide minimal housing for people with mental health issues, and and many of them have addiction problems as well. So it's a huge challenge to provide a safe place for people who are struggling with these concurrent diagnoses. What I came up here to talk about or to ask you a question about is I'm really impressed with the diversion program, and it continues to be very helpful for first-time offenders, youth and adults. But I have a question for Mr. Wise. I'm wondering how many restorative justice processes are used in the Hamilton-Wentworth School Board at this time, because a few years ago it used to be really, really effective in dealing with bullying, and I've facilitated a few healing circles, and when every person affected by an incident is heard and respected and honored as much as the other person on the other side of an incident, the truth comes out. We find, I talked to a coworker this morning, and her son is dealing with a situation at school, and they're finding out that he's being bullied, and they're finding out that the girl who is doing the bullying has family issues. Dad has addiction problems, and so it's a powerfully healing process that can lead us to informing us about mental health and addiction problems in the family, in the community, in the schools.
So I'm going to take that as a question on the use of restorative justice in the school system. Thank you.
Sure. So at our board, we really appreciate the use of restorative justice practices as an alternate dispute resolution. I think what the question initially started with is a few years back we had a substantial grant from the government that allowed us to do a lot of the practices. Naturally, sometimes when the money disappears, so do some of the services that allow us to do the same volume. The one part I would like to make sure we're really clear about, though, when it comes to restorative justice is it's a power equalization when you bring 2 people to the table. And if you don't do it well, it's harmful. And so you have to make sure that you have the structures in place, the know-how, the knowledge. You have to really be able to balance the power before you bring two young people, in which bullying is predicated on a power imbalance, and bring them at the table to try and find a peaceful resolution. It's only as good as the process undertaking it. So I always want to qualify that. That's not. It's a excellent tool to have. It's an excellent process to engage in. But it's tough work, and you got to make sure you do it well, or else you're just setting up more harm.
Any other comments on this point? Elizabeth?
If I could go to the issue of the diversion programs that was raised, because I
Please.
think that's a really important piece as we go forward with this. The Hamilton Drug Strategy, which is a group of over 100 agencies across this community who are working to reduce the harms from substance use, and they're working in 4 areas: in prevention, in treatment, in harm reduction, and social justice and justice. And our social justice and justice group has been working hard at this issue of diversion. And come back to some of the stuff that Tim talked about some of it is about stigma, some of it is about judgment, and there's a lot of that still around drug use, and really recognizing that this is a chronic illness that we're dealing with. It's a relapsing chronic illness, so people will get better and they'll get worse again, and they need the supports to get through that. But we need to move away from some of the ways that we've been managing those issues. And so, the police are often involved for good reason, perhaps at the outset, or because somebody doesn't know where to turn, but they are working hard to figure out ways that they can then bring these people into the treatment system. And similarly with our paramedics, when they're picking up somebody who's had issues with substance use, they're looking at how, rather than bring them to an emergency department where there may be some acute issue that some need to go for, they really need to get connected to the kinds of services that are provided in the community, or go somewhere to detox for a period of time. And we need a different way of doing those services, and changing how we think about drug abuse here in the community.
Thank you. Going to go back over here, Charlotte.
Hello. Sorry, my name's Andrea. My biggest concern is the funding, because, realistically, I see so many people come up to me and they want to get to a detox center, and it's a 7 to 10 wait, and they want that help, but in those 7 to 10 days, they could possibly overdose or die. So, where are we getting this funding from? Because obviously Doug Ford's not doing anything.
Okay, thank you. Appreciate the question. Let's talk about austerity in general and the effect on frontline services, because Elizabeth, you acknowledged at the front end that we have reached the limits of the system's ability to solve problems through new or expected enhanced funding levels. But on the other hand, there are still basic requirements that have a life or death impact on folks in this community. And how are we feeling generally about the resources needed to meet the expanding and, in some cases, crisis level challenges that we see in this report and that you see on the front line every day? Who wants to go first?
So perhaps I will kick it off.
Yep.
And then turn to these guys. I think, because I'm the one who brought up the piece about where we're at in terms of resources. And there is an issue. Health now takes up a huge proportion of the provincial budget when it comes to the tax dollars that are used around this community and around the province. And so, sitting back and thinking about how are those dollars invested, I think is absolutely key. You heard Tim talk about how he has to go and do something in order for somebody to get to services. And there are ways that we can improve how we provide services that might even be cost savings. But, we have a saying at the city that when you continue to improve, you reinvest in what needs to be done next. And so that's something I think that's absolutely critical when we're looking at things in a different way that we're going to do things with the Hamilton Health Team. The purpose is not overall to save dollars in some sort of way, but to look at where we can reinvest in the services that are so important to our community. So you brought up the issue of detox. That's certainly one that's top of mind. And there again, we have some barriers. I know Holly Raymond at St. Joseph's is working hard to figure out a solution there. And one of the barriers is they don't have access to somebody who can prescribe drugs for when people go into withdrawal overnight. And they don't have a way to get the drugs, if they did get them prescribed, from a pharmacy to the place where the detox is happening, because you can't put those kind of drugs in a taxi to get them from one to another. So you could come up with a very expensive solution, but we need to find some really elegant ones that are a lot more simple. So that's what we're working hard on. I'll turn it to...
So is there any other way we could make more funding for these detox centers and getting people into treatment? And is there Is there anything else we could do? I don't know.
Great question. Okay. Anybody else want to take one more swing at this one?
Terry, I might.
Go ahead, Jeff.
So I take off my research hat and talk a little bit about the work we've been doing with the Hamilton Health Team. I think there's two answers to your question. One is absolutely we need more resources to do that. I think to Elizabeth's point, there are some reorganization things that we can do and are hoping to do over the next year that will free up some spaces in a hurry. One of the things that we have been talking about, particularly with addictions, is that we know that we have a very short window when people say, I want help. You got to give them help right then and there. And one of the priorities that we're focusing on for the first year is to try and figure out the system so that we can get help right then and there. To your other point, it's going to be difficult to do that for everyone without some new resources and some new help. But I think there are some things that we can do when we say this is an absolute priority for our community. We need to make that happen. So I think you standing up and saying we need to make this a priority is really helpful and will help fuel this as we move ahead.
I'm going to make one other comment, and it's apolitical, but it's based on a history in political leadership in this town. And I would say to you that the challenge in Hamilton now for 25 years has been a fundamentally unfair way of supporting health and social services for a population base that comes here from well beyond our geographic boundaries. Anytime that you're a home to a psychiatric hospital, a prison, frankly, a number of residential care facilities that attract people from the broader community, and your funding base becomes only or mostly a municipal property tax base, you know that the ability of the population here, which is frankly poorer and older than its neighboring suburban communities, is going to be highly tested. And when we had the fight with the province about downloading 20 years ago, I said this is a disaster for the older urban centers in Ontario, because they are the places that the most vulnerable people go for services and often remain. And if you're depending mostly on the property tax base to support that, you will do that, frankly, in a way that is unsustainable. And I think that's proven to be true. This community has paid a significant price for short-sighted provincial funding decisions that have, advantaged some affluent communities and disadvantaged older urban communities, and I think there clearly is a political dimension to those decisions. I feel better having said that. Chris Fries.
Thank you. My name is Chris Fries from the Unicorn Rebellion. I am part of the queer community here in Hamilton, and I also do Drag Queen Storytime on Facebook every Tuesday at 4, so check it out. Which kind of leads to my question. I really appreciate this research and looking at it. If I'm reading it correctly, that you said that the LGBTQ2S plus community, only 50% said that they were feeling content or happy, and 25% of a subset said that that was the case. And I'm assuming that is, and I'm only making assumptions, is probably the trans community or the trans people of color community, which completely... It's devastating for me as part of the community, and I also know that the trans community, one of our most marginalized communities in the city, in Canada, everywhere, the rate of suicide is much, much higher, and the actually attempting suicide, just the attempting is like 50%. So I liked what you said, David, about bullying, because I think that it starts with young people and how we feel about our community and people in our community. And I like what you said about it's all of our responsibility. And I know that the school and the school board has some responsibility in that, but it is all of our responsibility in how we view and treat others. So what I'm asking you, David, specifically, is what would you ask the community for in support to help you, because it starts with kids and it goes from there. So what would you ask leaders, Hamilton, everyone here?
Great question, Chris. Can I just ask Jeff first, though, to confirm the statistical question you've asked, and then I'll turn it to David to respond specifically. So, Jeff,
Sure. You're right. When we looked at, so this is part of a recent research study that was just released a couple of, like a month and a half ago by some researchers, queer community and McMaster researchers that did a really in-depth study that, again, is an excellent piece of research. We took kind of the high level out. And there are some groups within the community that are well over 50%. I probably should have said that differently. Well over 50%, I think over 60, a couple of them. But the trans community was at 1/4 said that they were happy or very happy. So yeah, you're right.
Partner with us, be positive role models for our young people, get involved, be active, be engaged. Schools are community schools, so they're not just sort of HWSB or the Catholic Board or something. It's the community school, and so I think the community has to take responsibility to be partners in making sure that we are all sort of, I think, what's the slogan for Hamilton? It takes a community to raise a child. I think we have to model that in our everyday living, and I just think be partners. Find out what's happening at the school board and contribute. Look for the committees that we offer, join, encourage others to join, add your voice, shape the educational future for our young people.
Thank you. Unfortunately, we are seeing the clock tick down. I'm going to recognize a final question and then allow the panelists a short opportunity to sum up and offer some reflection.
Thank you very much. My name is David Hudson. I'm with the Hamilton Arts Council. I wanted to ask kind of the members of the board examples in the city of Hamilton that are working well in terms of community engagement. I know that part of the problem that's been raised is isolation, separation, and divisions within the community. And I wonder, just from your perspective, projects and initiatives within the community that are working well, and then also ways that within the community we can do better. What can organizations like the Hamilton Arts Council, where can we focus our energies to support in a preemptive way to help this problem?
You just did the work that I was going to have to do, so that's a perfect setup. So the closing minute that each of you have, let's first of all identify an optimistic note of something that is working, and then if you could, a takeaway on what we could be thinking about or doing, whether we're healthcare practitioners, interested citizens, supportive family members, or people struggling with mental health and addictions, to make this a better place for everybody. And I'm going to start at the far end, Jeff Wingard, and then we'll work our way back to David to finish.
Thanks, Terry. So, one of the things that I would think about in terms of positives, I'm a policy guy by background, but one of the things I remember is when the smoking bylaw came in, and it was a really difficult sell for restaurants and bars, and it was a difficult sell politically for city council. And they had the courage to step up and make that change. And
was one of the only issues that I ever received a death threat on as an elected official. But I'm pretty sure it was somebody stumbling out of a bar, upset that we were going to outlaw smoking. But I digress.
Yeah, but I think we're seeing the fruits of some of that. So I would think that where there's leadership and there's a clear policy way to address some things, that is strong. One of the things that I think about, it's actually Medora and Renee. And Chris, you've raised it, is really around the equity and diversity lens that we bring to this work, and that it's not really enough to just think about overall averages, that really we need to dig deep. We know that certain populations in this community are really disadvantaged, and the intersections of those folks are really disadvantaged, and we need to think about all of those complexities when we think about longer-term solutions.
Thank you. Tim.
Yeah, thanks for the question. So I think in terms of a positive thing that's happening in the community, from my perspective, the organization I would highlight is Keeping Six, which is an organization of people who use drugs and those that love and support them, is sort of the theme of the group. And that's a group that our organization has been working closely with to try to shape our priorities and shape how we respond to the different issues that we've been talking about tonight. That's an organization you can find on the internet if you're interested in learning more about them. There's information there that you can hear about. And I think from that, again, in terms of what could be done better, I think particularly in the healthcare community, what I've learned from that group and from talking to my patients, I think particularly around addictions, particularly around the issues we've been talking about tonight, my patients really have a lot of the answers and have a lot of insights. Can really identify a lot of the things and the holes in the system and where things fall down. And I think in healthcare in general, we're doing a very, very poor job of engaging that voice and and using the insights from people with lived experience on how to guide us in the future. I don't think we're doing it particularly well either, but we're learning how to do it, and I think as a group, the healthcare community in general really needs to do a better job of that.
Thank you. Elizabeth.
So I think there are some good examples where we are engaging with people, and look at the construction programs that have been done to engage youth and bring them into the trades and into really good, well-paying jobs as a result of that. You look at some of the stuff that's being done about graffiti, and how do we change our attitude around that, and look at how that's an expression of art in our community. And you talked about keeping six and people with lived experience, and it's been really gratifying in our work with the drug strategy to bring people in with lived experience and to truly listen to them, because they do have a lot of experience. And we're fortunate to, at the Hamilton Health Team table, to have two patient advisors. Bernice, I know, is here tonight, and John Fleming, who are leading that initiative. And we have people involved in every part of that in terms of moving forward. And I think it really, it has to become personal. It has to become about, reflecting on stigma, reflecting on trauma, reflecting on people's lives, asking about people, how they got here, not judging them, not looking at what we can do to fix them, how come they haven't listened to our advice, because we have to meet people where they're at, as David talked about with our kids. And we have to work with them and think about what we're doing, which may be accidentally, through no intention, continuing to traumatize people, continuing to express stigma, and make those changes. Make those changes at home, make them in talking to your kids, make them at work, and stand up and be part of that change.
Thank you.
And I would have to reiterate around the voice of lived experience, because I am a strong advocate of peer support work and how that can reduce barriers for individuals who are trying to access or connect with healthcare providers, because that can be very intimidating, that can be extremely scary. And so to be able to have a peer support worker who's lived that experience and has navigated the system and understands how the system works and has some providers that they might recommend or that they've really connected with, that makes all the difference with helping people to access service when they're frightened. We have a program called Talking About Mental Illness. So we have people with lived experience that we have somebody who works with them and coaches them to develop their story, and they go into the school system and they tell their story. We have a partnership with the Bulldogs as well, so we have hockey players with lived experience that go into the high schools and talk to students about their experience. And I think seeing that is very powerful. It reduces stigma, it broadens people's minds, it helps them to see people outside of how the media portrays people with serious mental illness, where you can recover, you can live a life that is meaningful and purposeful, and we're all good people fundamentally, and we all want help. And if peers can be sort of the avenue for that, then absolutely we need to support that, and more funding to have people paid to do that work is really what I think is encouraging to see.
Thank you.
I just sort of always want to remind people that we have schools that are full of dynamic, energetic, passionate, brilliant young minds who are challenging our perceptions on identity, orientation, the environment, reducing stigma. I think one of the reasons we're having these forums talking about young people's mental health is because young people are talking about their mental health. And they're doing an amazing job of smashing some of the stigmas. And I think one of the challenges we're having with the amount of services we have is young people are demanding services and are not just settling for go away or suck it up. So I think sometimes when we look at the data, and I don't want to lose sight of those who are not benefiting from what we have to offer, and I want to continue to strive until we are 100% in the well-being column. But let's not lose sight of those individuals who are doing well and listening. I think we've heard it here, including the voices. So I never want us to try and solve it for young people without making sure that, and they should be paid at the table too. So,
thank you so much. And as the moderator's prerogative, I want to say that I'm optimistic because of the strength of the partnerships. And when I look around the room and I look at the panel, I know the kind of blunt conversations we've had about the things we need to do differently, about the problems that we can't solve in isolation within the walls of our own institution, and about the need to take risks. And I'll identify something, because I'm about to call on my board chair to formally thank you. And one of the challenges we faced as a funder was we've got an enormous endowment because of the generosity of people in this community that passed $200 million this year. But we're one of the few foundations in the country that has had boards that have allowed us to unlock that, to invest in things like affordable housing. And one of the challenges in this community as property values have escalated is that the providers can't tie up the property, do the environmental and the planning approvals, and then stack the capital to make them happen, because by the time they get to that point, a private developer has paid 3 times what the property was listed at. And in several instances now, we've gone out on the limb with folks like Indwell, Parkdale Landing being a great example, and said, we are going to finance 100% of the purchase price. We're going to find a local counselor who will cover the interest cost, low interest cost on the loan, and allow you to get your approvals in place and bring those properties to reality. We've done the same thing with them on the Royal Oak Dairy property, which to date has really been a blight on a neighborhood, and is going to provide dignified housing to vulnerable people with addictions and mental health issues. That only happens with volunteers and board members who say we should be taking reasonable risks to do more with the stuff that's at our disposal. And I see that every day in the different institutions that we work with, and I'm honored to be part of a community that is so determined to deal with these tough issues. And I'm also inspired by the turnout we inevitably get by engaged citizens who want to be part of a solution. I'd be remiss if I didn't acknowledge a couple of elected officials who joined us here today. Cam Galindo, a young school trustee from Stony Creek, way to go. It's great being a young elected official, right? You lose your hair, though, I will tell you. My favorite city councilor, Maureen Wilson, is in the back row, councilor from Ward 1. And we have a number of former board chairs and board members of the Hamilton Community Foundation who have served us so well over the years, from Vincie Trevelli to Dr. Justin Cooper to Paul Gibble, and to the guy I'm going to ask to come up now, retired DeFasco executive but active citizen about town, and our board chair, Bob Savage, to formally thank this panel.
Hate being introduced by Terry Cook. I now understand that completely. On behalf of the Board of Directors of the Hamilton Community Foundation, I'd like to first of all thank you all for coming. There's obviously a lot of talent in this room on the topic of mental health and well-being. And so if this event helped you in any way, we really appreciate that you participated and helped us this evening. I'd like to thank the panelists and the speakers for providing your insight and knowledge and really bridging this conversation with us tonight. It was a fabulous evening, and I really appreciate it. Thank you also to Terry Cook and his team for putting on this event. The Hamilton Community Foundation is a small and mighty group at the same time. They do a lot in this community day in and day out. Terry got a bit of advertising there right at the very end, but I can't underestimate or overestimate enough what his group does for this community. And also, they bat above their weight nationally as well. The Hamilton Community Foundation is known nationally for what it does. And Terry and his team are asked quite often to travel to other communities and to find out what we're doing in Hamilton. So our vision in the Community Foundation is a vibrant and inclusive community. And I hope that this helps us to achieve that tonight. Thank you very much for coming, and I wish you all a safe drive home.